Topbed Talk.
I'd like to welcome to the stage Professor Sandy Jack, who is a professor in Prehabilitation medicine at Southampton University and a consultant clinical scientist. Thank you, Sandy.
Hi, thank you so much for inviting me to talk about our trial at this fantastic conference. So I'm going to talk about our Wessex Fit-4-Cancer Surgery Trial. So we've already talked about this in some length. So prehabilitation is defined as the process of enhancing functional capacity for an individual to enable him or her to withstand a stressful event. So functional capacity, we've talked about physical fitness, but also metabolic and psychological or mental health. A stressful event is surgery, and you wouldn't run a marathon without training for surgery, hence why we think that prehabilitation, and a lot of other people think, it's really important. The really important thing that James alluded to as well is that you have to get your patients as early as possible. We try and get the patient as early as we can do in the pathway. However, it's a lot of waste in the pathway, and we found that sometimes we've even not got 2 weeks to be able to do this. So we think that actually it should be at MDT, and that we should approach the patient for a Fit for Life school and then screen and assess the patients before they actually have a cancer diagnosis. Now, that is very controversial, but it's the only way that you're going to confer the most benefit from your prehab. And if patients haven't got cancer, great. And they don't have surgery, great. But if they're having cancer treatments and then go on to, or any comorbidities, then we pick all of this up. And it's really important that it's a unique time to talk to a patient, making every contact count. And patients want this. Our team are fantastic. They say to the patients, we are in partnership here to get you through your surgery. So you've also seen this diagram before, and I'm not going to labour the point other than the fact that functional capacity shown here, and this is prehab, no prehab, surgery, and then the trajectory back to normal life. Is that we've seen in over 200 patients that cancer treatments significantly reduce your physical fitness and functional capacity. So actually the line could actually be here. And if you intervene and exercise train during cancer treatments, then you can ameliorate or stop that fall. So we don't know how much the fall is after surgery, but what we do know is that if you have prehabilitation, then your trajectory back to normal, and that's all patients really care about. I want to be back to normal within 1 year. Is much faster. And these patients may end up in a nursing home, so significant cost. It is across the whole cancer continuum, and it should also be alongside and in conjunction with enhanced recovery. Our prehab family, that we talked about this in Montreal and Eindhoven, we think that it should be a 3M model, so it's multimodal, so it's, as June talked about at length, it's physical fitness, it's nutrition, it's psychological support, it's multiphasic, it should be throughout the whole patient cancer continuum, so they should have it before surgery, after surgery, if they're having adjuvant cancer treatments, and then if they have further surgery. It should be multidisciplinary or interdisciplinary. We need the whole team to work together, and we need the community. This is a public health issue, and we need the sports industry to help us deliver prehab to the universal, to 100% of patients. So where's the evidence? So this is a single centre trial from the Barcelona group, personalised prehab in high-risk patients undergoing major elective surgery. And they showed that the control group compared to the exercise group, the endurance time was significantly increased with the patients that exercised. Also, this YIPAS, which is looking at more like physical activity, not exercise, was also statistically significant. What they also showed, and this is the first trial that was powered to show this, in high-risk patients, there was around 50% reduction in complications. So this is the kind of triangle that June put up, but this is the long-term plan from NHS England. And this is looking at their triangle of their ambition, which I think is rather ambitious, is to have the 100% of the population, so this is universal, should have some support, and patients need support even just giving them advice and another flipping leaflet. They actually want the support and understand what they need to do to get fit. And these are the targeted patients, so patients with long-term conditions, mental health conditions, and these are the specialist group that probably have more complex needs. The problem is, as June said, you may be this for nutrition, this for mental health, and this for physical activity. There's 62 variations in this, and we also haven't got an accurate screening tool for physical fitness to be able to assess patients. So it gives us a problem. If you want to do universal, then that can be in a community gym. You can manage any health problems, and that can be in a community gym. And this may be in hospital, but again, if their complex needs are resolved, then they can also be in a community gym. So we've got WesFit is an NHS England funded randomised control trial. We talked to the Wessex Cancer Alliance, and I have to say a big thank you to Sally Rickard, the director, Matt Hayes, who's the clinical director, and Fran Williams for supporting this. We went to them with the concept we wanted to roll out Prehab in the community, and they agreed we could do this as a randomised control trial. It's not only a randomised control trial, it is service implementation. It's part of the cancer transformation bid or programme, and it's part of something that Macmillan does called the recovery package. We got £2.3 million to do this. It's called Wessex Fit-4-Cancer Surgery Trial, or fondly known as WesFit. It's a pragmatic, and pragmatic should be underlined, factorial design randomised control trial to assess the efficacy of implementation of a prehab programme in patients undergoing elective major intracavity surgery. It's in Wessex at the moment, but through the traction and the perioperative medicine and our friends and anaesthetists, we are rolling out across the south. This is the flow diagram. So the inclusion criteria is male or female patients over the age of 18 who are planned treatment for major intracavity surgery. These are colorectal, upper GI, thoracic, HPB, urology, and head and neck. So the pathway starts with a cardiopulmonary exercise test. We have to screen for that, and if patients have no contraindications to CPAP, then they are approached and consented to the trial. There's then randomised to one of 4 arms, so this is control, exercise, psychological support, and the combination of both, which we hope this is going to be commissioned with also nutritional support when we know what we should be giving patients as a nutritional support. CPET's repeated before surgeries, planned surgery, and then we follow patients up for 1 year. This is the infographic that really talks about what's going on. So we get the patients as early as possible. The minimal time is 2 weeks, the maximum time is 15 weeks, so when patients are undergoing cancer treatments. As I say, we want to get them as early as possible. The main reasons for patients declining the trial, or that we can't include the patients, is lack of time on the pathway. Travel is another reason, and we are recruiting around 50% of patients that are approached consent to the trial. We then follow patients up after surgery, 6 weeks or when medically fit, and at 12 weeks, because we then want to be able to tell the patient that they are actually better and they're fit and they can go back to their physical fitness and their prehab programme, rolling into rehab. Patients really get this. They've been on the bike, they've done a maximum test, their stitches haven't burst open, they're all going off buying bikes. And we are changing behaviour, and this is through the support of our teams. We don't stop the clock because we think that we need to prove to NHS England they have antibodies about stopping the clock. We met Simon Stevens recently, and he's like, you were telling me that prehab can get early diagnosis and you can do this within the cancer targets? Yes, we can, if we can see the patient early enough. And there's some work that we've been doing which will be presented as an abstract today by Sam Leggett, looking at remapping pathways. We can exercise train them for 2 weeks with a significant increase, and Andy Bates, who's doing an abstract as well, will present his trial where he trained rectal cancer patients within 2 weeks. And the groups are controlled, so this is standard care, but we assess patients and do all the assessments throughout. that's exercise, and this is all in the community. So once the patients have had their CPET, we then derive their training program. It's delivered in the community, so community gyms with personal trainers. And then the psychological support is in a wellbeing centre, and the combination of exercise and psychological support are in community gyms or health and wellbeing centres. We follow patients up for 12 months and they wear an activity monitor. During the time that they have their exercise training, we also do something called healthy conversations, so SMART goals, to encourage patients to change behaviour and for them to be empowered to go back to the gym after they've had surgery. This is our training program. These are 2 patients sat on the bike here. When we were talking about do patients blame themselves if things go wrong, he's an example, but not really. So Ray here, he had a complication. He was diabetic, hypertensive, and obese before his surgery, before he came to us, and then he performed a Prehab trial, and he was none of the above when he then went to surgery. He did have a complication, but he said, Sandy, it was a double whammy of goodness. She saved my life. And he's encouraging our patient on the bike here. Our training program is that you have cardiopulmonary exercise testing as soon as you possibly can. And this was after long course chemoradiotherapy. And then we do 30 minutes or 40 minutes of exercise training and repeat the CPET. So this is a responsive training program. To this trial, it was a 6-week training program in rectal cancer patients. We had 94% adherence, and it's similar throughout all of our trials, up to 15 weeks of exercise training in esophageal and gastric cancer patients. Then we had 87% adherence, and this was all done in hospital. So our exercise training we derive as 80% of your anaerobic threshold, so below anaerobic threshold, and 50% difference between anaerobic threshold and peak. So this is soft interval training, or HIIT. This is the visual here that patients see. These are the hills that they see and the heart rate, and they do this, and they do 2 minutes of severe and 3 minutes of moderate intensity. So this is like training for a marathon. The psychological support is person-centred counselling and healthy conversations, and Chloe Grimmett's going to talk about this in her talk tomorrow. The sample size is medium length of stay. In control group is 7 days. So we then powered it for a clinically meaningful difference of 1 day reduction in length of stay. This is driven by the commissioners. It's not our chosen primary outcome, but certainly we weren't going to turn the money down. It's 85% power. It gives us a sample size of 1,560 patients with 20% dropout with recruitment over 3 years. There's no interaction between the interventions. And 1 year follow-up period. These are the community gyms that our bikes are in there, and these are intelligent bikes that you can deliver the training program on a cloud base. This is Wessex. It's only quite small. Our trial was originally only in Wessex, but we've now got national rollout. Our primary outcomes, post-operative length of stay, and there's a lot of other secondary outcomes, including disability-free survival, which actually we think is probably one of the most important things. So are you alive at 1 year, and are you disability-free? CPET variables, physical activity from physical activity monitors, health-related quality of life, cost-effectiveness, disease-free survival. We're also doing a raft of radiological or mechanism trials, mechanism outcomes looking at sarcocachexia, tumour staging, and micronutrients. Our recruitment is shown on this graph here. We're somewhere around here, around 130 patients, and we hope to get our sample size within 3 years. This is our future. This is a future model. This is a fantastic place that's in Coventry, a community-based gym, which was originally pulmonary rehab and cardiac rehab. And there's a lady stood on the treadmill with her handbag. Our ambition is a centre for healthy living, and we are in the process of putting our business case together to deliver a service within Southampton. Thank you very much.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.